Hello, everyone, and welcome to this educational program titled Small Steps, Big Impacts, Nurturing Infants the PKU Start Way, brought to you by VIA, VitaFlow in association with you. I'm Elisa Vetta, registered dietitian on the medical affairs team here at VitaFlow North America, and I'm also joined by my colleague, Maria Ortego, also a dietitian on the marketing team. Before we dive into the main content of this program, which is why you are all here, let's take a moment and review a few housekeeping items. Financial support for this presentation was provided by VitaFlow USA. The views expressed herein are those of the presenter and do not necessarily represent Nestle's views. The material is accurate as of the date it was presented and is for educational purposes only. This program is not eligible for CPEU. Just a few quick notes. The slide handouts will be sent to you via email after the broadcast. We will also have a live Q&A at the end of this session, but feel free to submit your questions at any time using the questions feature on the bottom hand corner of your screen. And we do encourage you to type your questions in as we go along, so that we can streamline the process at the end and get to as many questions as possible. Now, let's meet our speakers for today. Our first speaker is Suzanne Hollander, a metabolic dietitian at Boston Children's Hospital with 11 years of clinical experience. We are also joined by a special guest, Betsy Madonna, a mother of a child with PKU, who will share her experience of transitioning to solid foods with her child. Also joining is Chanel Suarez, metabolic dietitian from UCLA, and she will participate in our question and answer time at the end. So welcome to all of our speakers, Suzanne, Betsy, and Chanel. Today we'll focus on PKU Start, a product now available in the US and established in other countries for several years. PKU Start is an amino acid-based fee-free powdered infant formula designed for the dietary management of PKU. Its formulation aligns with the latest scientific evidence in infant formula nutrition and PKU management. With you from the start means that we aim to provide valuable support to you and your families from the beginning. We offer a comprehensive kit for infants who will begin nutrition therapy. This kit includes 8 cans of PKU Start formula, a gram scale, should you choose to use this tool with your family, and a simple and reassuring parent guide. You can choose to have this kit delivered directly to your clinic or the family's home. Now, let's dive into Suzanne's portion of the session, where she will walk you through the first 6 months of PKU diet therapy.
Thank you so much, Elisa Betta, for the introduction and information about PKU Start. And thank you to VitaFlow for inviting me to be here today. And thank you to everyone attending the webinar to be here to hear about feeding babies with PKU. So I'll start with a broad overview of what PKU nutrition management looks like in the first 6 months of life. So you can see here this big at a glance. The whole process begins with diagnosis, and that typically follows a positive newborn screen result. So depending on the day of life that the newborn screen comes back with the result, the diagnostic Phe level will be obtained, and this level could be very elevated. For individuals with PKU who remain on treatment for life, this diagnostic Phe level could be the highest lifetime blood Phe level that they experience. So the first step in nutrition management is with the goal of rapid Phe level reduction. So we're trying to get that severely high blood Phe level down very rapidly for the infant. At this point, fee-free infant formula is introduced, and it's introduced in a large quantity that will help bring the Phe level down into target range very rapidly. Once the blood Phe level is down, we'll then titrate the Phe source, or in the case of breastfeeding infants, the fee-free formula in order to maintain stability of fee levels between 120 and 360 micromoles per liter, or 2 to 6 milligrams per deciliter. So this titration of fee source will occur throughout the infancy. And finally, we'll begin the introduction of solid foods around 6 months of age. With the solid food introduction, though, the infant's liquid nutrition source remains the primary source of nutrition for many months after that. All throughout this time, blood fee monitoring is really the mainstay of therapy, and it's recommended that it's done weekly during infancy. So I'll dive deeper into the introduction of nutrition management in PKU. And this image on the right is from the PKU Start Practical Guide, and it's available to healthcare providers on VIA. But I'm going to zoom in on it in order to take a closer look. So a high fee level will trigger the implementation of PKU nutrition management for an infant. In some cases, this could be done based on a high probability newborn screen level that's taken around 24 to 48 hours of life. In other cases, though, providers might wait for a diagnostic fee level, which would typically be taken a few days after the newborn screen result. So if the fee level is elevated above 360 micromoles per liter, we'll implement a fee-free formula such as PKU Start. So depending on the diagnostic fee level and the clinical circumstances, which really is primarily the severity of that fee level elevation, and then also whether or not the baby is breastfeeding or bottle feeding, and then as well as the access to fee levels, we'll take one of two approaches. So the first approach on the left would be used with a more severe blood fee elevation. And that approach is stopping all fee-containing nutrition and giving PKU Start only for up to 48 hours. This approach is something that we call a fee washout period. The second approach on the right is one that we would use with a less significant blood fee level elevation, or sometimes in cases where we can't get a rapid enough blood fee result after a washout period. So in those cases, we would introduce a combination of fee-containing human milk or standard infant formula along with PKU Start. And then once fee levels are within target range, we'll titrate human milk and standard infant formula, reintroduce them if they were stopped, and all with the goal of achieving fee level stability within the target range. And now I'll go into a more in-depth look of what PKU Start looks like as the sole source of nutrition during that washout period, or that 24 to 48 hours. So as I just discussed, this would be used if a blood fee level is very high, and the goal is to rapidly drive down blood fee level. Typically, the washout period will last no longer than 48 hours, and depending on the time to result a diagnostic fee level, this period usually starts around day 4 to 7 of life. Step 1 is to introduce PKU Start, and in order to do this, we have to provide education to the family on mixing PKU Start. If it's a family who's been used to breastfeeding, bottle feeding could be new to them, and mixing formula could be new. And if it's a family that was using standard infant formula, the specific mixing guidance for PKU Start is likely to differ from the formula they were using. So PKU Start should be offered on demand to the infant, and infants should always be fed to appetite. We want them well fed from the start. So to this end, I often teach the family a per bottle mixing instruction. So they're encouraged to make the bottles on demand to feed the baby when they're hungry, just like they would with any other bottle feeding with or without PKU. So although this is a washout period, with breastfeeding infants, we sometimes would still encourage the mother to bring the baby to breast for a very short period of time, once or twice a day, in order to promote that early breastfeeding bonding and skill. And we would also encourage breastfeeding mothers to express milk in order to establish or maintain their supply. If it's available to the mother, working with a lactation consultant during this time can be really helpful at this stage. So for all newborns with PKU, and especially those undergoing this PKU start only phase, it's really important to get a feed level closely following the washout phase. That both ensures that the level has come down significantly enough, and also that the baby is not experiencing hypofeed. And then finally, once the feed levels have approached or are within the target range, human milk or standard infant formula is reintroduced in an amount that's estimated to keep the level in target range. And I'll go through how we'll get to that estimation a little bit later in the presentation. So during the reintroduction phase, sometimes babies will have persistently high feed levels, and then we'll need to do a second sort of mini washout to get them back down. I'll talk about that in the case study. And then conversely, some infants are growing so rapidly during this phase that they may have persistent hypofeed following a washout, in which case we would want to provide the feed containing source in a larger quantity for a short period of time to get them back on track and get the feed level stable. So intact protein from human milk or standard formula will be adjusted based on the blood feed levels. And in bottle-fed infants, the amount of milk or formula can be increased to raise the blood feed level, or it can be decreased to lower it. We can actually measure it and then increase it or decrease it. In breastfed infants, PKU start volumes will be adjusted with the goal of increasing or decreasing the baby's appetite for an intake of milk at the breast. So in response to a high blood feed level, increasing PKU start will decrease the baby's appetite for breast milk, resulting in lower feed intake. And in response to a low blood feed level, decreasing PKU start will increase the baby's appetite for breast milk, resulting in higher feed intake. It's important to give the combination of both PKU start and the feed source to meet the baby's overall nutrition requirements. And again, we do this typically by relying on the baby's appetite to guide total volume intake. So it's not recommended to limit the baby's total daily volume intake, but instead to adjust the ratio of that volume and how much of it is coming from PKU start versus the feed containing source. And that will help achieve feed level stability. So as I discussed, the combination of human milk and PKU start are providing all of the infant's nutrient needs until 6 months. At 6 months, solid food introduction begins and will slowly become progressively nutritionally meaningful in the diet. But it really isn't until later in the first year that this liquid nutrition is no longer the primary nutrition source. Chanel Suarez will discuss this at great length during next week's webinar, From Bottles to First Foods. So there's some important considerations in initiating this PKU nutrition management. So firstly, feed levels should be monitored weekly in order to achieve stable levels within the treatment range. Occasionally, levels may need to be done more than once per week, especially when first starting a baby on PKU start. But in many instances, doing feed levels more than once a week isn't practical or actionable because of how long it takes to get a feed level result. So in our clinic, we try never to have families actually complete a level unless it's something that is really required for management decisions for us. PKU start and human milk or formula can be given together at each feed or by alternating feeds throughout the day. So for example, a breastfeeding baby may get a measured volume of PKU start before every feed and then finish every feed at the breast. Or the infant may get a larger measured volume of PKU start every other feed and then do a full breastfeed for the alternating feed. So in our clinic, which way we would advise the family to do it depends on their own family preferences and circumstances. It also depends on the feeding frequency of the baby. So it's important to ensure that the baby's getting the correct volume of PKU start and of the feed source if it's able to be measured. And again, it's critical that the baby be fed to appetite, so we're never limiting their total volume intake, and instead adjusting the amounts of the different nutrition sources to get the feed level into the target range. And weighing the infant at every clinic visit helps ensure growth goals are being met. It's during this early phase, it's important to keep in mind that growth trajectories can change during the first 6 months. So we want to have reasonable growth goals for babies and consider those for each individual infant. So here's a few considerations during that really early phase, those first like 2 weeks of life with a brand new baby starting on their PKU start. So newborn intake varies, but it is often between about 45 and 90 milliliters or 1.5 to 3 ounces per feed per baby. So families can track wet and soiled diapers in order to monitor for intake adequacy. They can also discuss this with their pediatrician, and families really should be encouraged to have these conversations just like other caregivers would for babies without PKU. Babies who have not yet regained their birth weight may need to be fed more frequently and especially may need to be woken up during the night to feed. And as we already discussed, breastfeeding mothers should be encouraged to express milk to maintain their supply during PKU start feeds. This is especially if there's a washout period, but should happen like throughout the PKU start feeding process. So this next part says maternal baby skin to skin, but really skin to skin contact with any caregiver can be used to promote bonding for families, and this is regardless of the feeding method. For breastfeeding mothers, the skin to skin, along with short periods of breast latching, may help promote breastfeeding, even during a washout period. And then, of course, the pearl today, which I've said already, is that infants should always be fed to meet their levels. So in the PKU Start Practical Guide, we go through 2 methods for calculating the feeding plan using both breastfeeding and bottle feeding. There's one of the methods uses precise feeding volumes and the other uses feeding volume percentages. I'm going to go through in detail method 1, which is using precise feeding volumes using PKU Start in a breastfed infant. So we'll start by estimating the total volume intake per day of the baby, which we estimate using sort of a modest 150 milliliters per kilo in a 3.5 kilo baby. And that comes out to 525 milliliters per day of intake. If the baby's usual volume intake is known, that can be used here as a starting place too, but typically in a breastfed infant, we don't know their total volume intake. So now we'll estimate the baby's feed need. So feed needs vary between 130 and 430 milligrams per day. And where you estimate the feed need to be is going to depend on the baby's size and mostly on the baby's feed level elevation. For a baby who had a very high diagnostic feed level elevation, we would estimate that they would tolerate the lower end of this feed. So we've estimated 150 milligrams of feed per day as the feed need for this baby. Now we estimate how much human milk is needed in order to achieve that feed need. So using 47 milligrams of feed per 100 milliliters of human milk, we get 320 milliliters of human milk needed to provide the baby's feed need. The human milk will not actually be measured. We're just going to use this information as a place to start in estimating the PKU start prescription. So to meet the remaining fluid needs using PKU start, we take our 525 milliliters total volume and subtract the 320 milliliters of human milk needed to achieve the baby's feed. This leaves us with 205 milliliters of PKU start per day as the total volume prescription. We'll now divide the total amount of estimated PKU start by the number of feeds per day, and we've estimated about 8 feeds per day, or a baby who feeds every 3 hours. And this comes out to 25 milliliters of PKU start per feed. So the goal would be to feed 25 milliliters of PKU start prior to each breast feed, and then allow the infant to feed at the breast to appetite. Or we could alternate feeds with 50 milliliters of PKU start, alternated with full feeds at the breast. So they would get 4 feeds of 50 milliliters of PKU start and 4 feeds per day that were breast feeds. Now, up to this point, this is really all work that's done by you, the healthcare professional, and this is not information that the family needs to be able to access or have full access to. So we always want to think about then making this information more logistically achievable for the family and something that they can do while they're tired with a newborn at home. So I would recommend simplifying this a little bit into more easily measurable quantities for the family. So since it all was an estimation to begin with, we take it and get as close as we can with 30 milliliters or 1 fluid ounce of PKU start prior to each breast feed, or alternating feeds of 2 ounces of PKU start with full breast feeds. So as I mentioned before, this information is also available specifically in the practical guide on how to do something very similar with standard infant formula. And then also how to do this using feeding volume percentages. And this volume percentage calculation really, it sort of depends on how your brain works, whether you like to do precise feeding volumes or come up with percentages. But ultimately, the prescription that you deliver to the family is going to be about the same. So I'll go through some reasons for high blood feed levels and how we might intervene. So the first reason is an excess intake of intact protein from the human milk or standard formula. So anytime this is suspected, I just always like to confirm how the family is mixing and make sure that any instructions they've been given were given clearly to them in a way that they understood, and really reviewing that mixing and measuring of feeds and formula. And then if we find out they are in fact giving it as prescribed or as intended by the provider, we'll then adjust the prescription and adjust the amount of PKU start needed to meet the baby's feed tolerance. Again, with an adequate intake of PKU start, we want to confirm the mixing and confirm the prescription. And then we also want to think about access to PKU start. If families are concerned that they might run out, they may be limiting the amount that they're giving in order to ensure that they have adequate access through the month. So always troubleshooting those access issues as well. And then there could be short-term symptoms that are contributing to a lower intake of the formula, such as colic or constipation, illness, teething, pain, and those are all things that can be addressed with the help of the pediatrician. So we'll increase PKU start prescription as needed if we suspect inadequate intake. And then catabolism or slow weight gain is another thing that could contribute to a high feed level. So we want to monitor the weight frequently to better understand the growth trajectory and make sure the baby is getting enough total nutrition. We also want to rule out illness and infection, which can contribute to catabolism. With a short illness that results in a mild feed level elevation, we might expect that to come right back down while the baby stays on the current prescription. But if the feed level is elevated persistently or elevated very high, then we may need to make a change even in the presence of illness. So we also want to encourage optimal total volume intake and frequency in order to encourage adequate growth and prevent catabolism. A change in the blood Phe monitoring routine could also result in a change in the blood Phe level, both a high level or a low level. And there's so many things that contribute to when a family does the Phe level. For example, if they're testing at home, they might need both caregivers to be present. And if they're taking the baby to a lab, that's a whole host of other logistical concerns. So really, unless the change in the monitoring routine is causing us to be completely unable to monitor the baby's blood Phe level trend, we usually just ask the family to do it whenever they're able to and whenever is most convenient for them, and then we can adjust the prescription as needed on our end. So now I'll go through some reasons for low blood Phe. And one initial consideration with both highs and lows is that unless the Phe is very low or very high, it may be worth waiting a week in order to see what the trend is and if the level sort of normalizes on its own. So for example, with low blood Phe levels, if the level's less than 120 micromoles per liter, but not truly in the hypo-Phe range, which is less than 30 micromoles per liter, we would probably wait and see kind of what direction the Phe level was going in on the current plan. So the first reason for a low blood Phe level that we think about is inadequate intake of the intact protein source, or just inadequate intake of Phe. So this could be from excessive intake of PKU start, which would lead to inadequate Phe intake. Before changing the prescription, again, confirming what is actually happening at home. So we're always making changes that make sense for what's really happening for the baby. And then early on, I also, with a breastfeeding infant, I also think about if breastfeeding or breast milk intake could be inadequate for some reason. So this would be another time to assess how the baby's feeding or if they're overfeeding on PKU start. Another reason for low blood Phe could be anabolism or a rapid growth phase. They're just using up a lot of the Phe that they're taking in. So as able, monitoring weights can help assess the rapidity of growth. And many babies may experience low or slightly decreased Phe levels during these rapid growth phases. This is one reason why I like when it works for the family to have families do a per feed mixing plan, because then when the baby is growing more, they actually are taking more volume in per day because they're in more Phe in per day when they're hungry and feeding more frequently. And then finally, again, the same considerations about the change in the blood Phe monitor routine as we already discussed. Here's some mixing tips for PKU start. And caregivers can choose to prepare one bottle for a single feed or a 24-hour batch. And that's something that you can talk to them about and sort of weigh the pros and cons and what might work for them in their home. So when we think about preparing one bottle at a time, we first pour the recommended amount of water into the bottle, instruct the family to add the prescribed number of scoops or grams of PKU start powder to the bottle, cap the bottle and shake it well, and then feed the baby immediately. And once the feeding begins, they can use that within an hour. If the family is preparing a 24-hour batch, they would pour the recommended amount of water into the container, add the prescribed number of scoops or grams of PKU start to the powder. So one thing in our clinic is that if families do want to use the scoops, I usually recommend a per bottle mixing method. And if they want to do a 24-hour batch, we ask them to use a gram scale. Adding up, like 20 scoops when you're tired and like making sure you keep count can be really hard for caregivers. So if they're doing more than like 3 to 5 scoops at any given time, we usually recommend that they go to a gram scale. They would then similarly cap the container and shake it well, and then refrigerate it and use it within 24 hours and sort of pour it out into the measured quantities as it was needed for the baby. I'll now go through a case study that brings some of these important points together. This was a family that I had the pleasure of working with. This was an infant who was breastfed and using PKU Start throughout her first 6 months. So we started with a positive newborn screen, and the feed level was 580 micromoles per liter. And as always happens, of course, came in on a weekend and there was a lot going on. So it wasn't until day of life 5 that we received the confirmatory feed level, which was over 1,300 micromoles per liter, and decided to initiate a 48-hour feed washout. So this was the family's second baby. It was a second time breastfeeding mom. This was their first baby with PKU. And both parents were highly health literate and able to follow instructions really like to the T, and ask really curious and interesting questions about their child. So we started with PKU Start only. And then we did allow for 1 short breastfeed per day in order to just help with the feeding routine and the milk supply, and then encourage the mother to express milk every 3 hours. After the 48-hour period, they were instructed to give 30 milliliters of PKU Start before every feed, and then with that 30 milliliters, finish by feeding the baby at the breast on demand. And the goal with this plan was a very rapid feed level reduction, which was mostly achieved, although the feed level at day of life 8 was still higher than we wanted it. And I think largely this may have been due to a misestimation of the baby's appetite and how much the baby was really able to transfer milk pretty early on in this second time breastfeeding mother. So at day of life 8, we changed the instructions. We had them give 2 full feeds of just PKU Start, and those were really 90 ml feeds at this point. And then after those 2 full PKU Start feeds, we went with a plan of 45 milliliters of PKU Start before every feed, and then finishing the feed at the breast. They fed the baby on demand throughout the day with this plan. By day of life 10, the feed level was down nicely in target range at 266 micromoles per liter. So we continued with this same plan of 45 milliliters of PKU Start and finishing feeds at the breast. This really achieved really consistent, stable feed levels for this baby throughout the first month of life. So some things to think about in the newborn period. As you saw with high feed levels, we added more PKU Start, and we didn't try to limit the number of total feeds per day in order to control those feed levels. We wanted to always determine the simplest mixing instructions for the family. For this family who was breastfeeding, they wanted to do a little bit of PKU Start before every feed, and that worked really well for them. So we think of bottles using ounces and scoops. It could use milliliters and scoops as well. And then large batches using milliliters or ounces and a gram scale. Again, for that reason of just losing track of the scoops with a large volume. We also want to think about a realistic feed turnaround time, especially during a feed washout period. If you're not going to be able to get a feed level back for a long time, it can be sort of tricky to wash the baby out or sort of know where things stand after this initial washout phase. With any of our families who are breastfeeding, we want to remind them from the beginning and throughout their breastfeeding journey that breastfeeding has a safe backup plan, and the safe backup plan is using a feed-containing formula. And again, not all families have comfort and literacy with the healthcare system. This case really highlights a family that did, and they really understood and asked really pertinent questions. But we want to always make sure that the lines of communication are open and that it's clear to families how they can communicate with their healthcare providers and with the clinic, especially in between visits. So now we'll look at the next few months of life for this baby and how we adjusted the PKU start to maintain those blood Phe levels. So just as a reminder, in month 1, the baby was maintained on 45 milliliters of PKU start before each breastfeed, and then finished feeding at the breast and was fed on demand whenever hungry using that method. At month 2, we started to see the levels trend down toward the lower end of treatment, of the treatment range. And so at this point, we had the mom add 1 exclusive breastfeed per day. And that was both to maintain Phe level stability and also just, it was a nice feeding time for the mother and baby. We saw 1 very mild illness-related Phe elevation. And then in month 4 to 5, the family had the goal of introducing bottle feeding in order to prepare for the mother's eventual return to work. So when being fed with the mother around, they maintained the plan of 45 milliliters of PKU start, followed by a feed finished at the breast. And when the mother was not around, they did a bottle feed of 60 milliliters of PKU start with 60 milliliters of expressed milk. And you'll notice the volumes are different, and this was done rather intentionally and also sort of by a guess and test method, and this seemed to work really well for them, both logistically and for the baby's Phe levels. However, at month 5, we noticed an elevation. There was an illness during this time, but the Phe level was so dramatically elevated that we felt like the elevation was likely both due to the feeding and the illness. So our response was to increase PKU start in the ratio in order to control the blood Phe level. So we did 60 milliliters of PKU start prior to each breastfeed, or a bottle of 90 milliliters of PKU start with 60 milliliters of expressed breast milk. So what you can see is really happening between month 2 and month 6 is this total intake per day is increasing for the baby, which is just what we would expect for any infant, regardless of whether or not they had PKU. So things to think about in the first 6 months. Family goals and needs change. In this case, the family wanted to introduce more bottles and prepare for the mom to go back to work. It's important to check in and make sure that whatever feeding plan is currently in place still meets the needs of the family. We want to establish both realistic and regular Phe level testing. For a lot of families in our clinic, this means testing at home the same day every week. And then there's a pattern of when they test and when the Phe level results and when we can intervene on that. So sort of getting that timing just right. As we saw again in this case, the total liquid volume intake is going to increase, usually until about month 5. There's some variability, but then it stays relatively constant until weaning. So liquid nutrition remains the primary nutrition source for many months after solids are introduced, but the total liquid volume does not tend to go up after about month 5. And again, throughout the whole process, we want to reiterate that breastfeeding has the safe backup plan, and we can use it at any time that it's needed. And a lot of times early on in the diagnostic process, we encourage families to reach out, or we inform them that there's other people in the community with PKU who they can contact. I think reminding families about this throughout the first 6 months is really important. They're not always ready to hear it in the diagnostic phase, or they're maybe not as ready to act on it in that early phase. So we always like to remind our families about the local and national PKU community that they could have access to. And so finally, for this baby, looking at the nutrition management that led to solid food introduction. In month 5, we had we started education with the simplified diet. This baby was not going to be fed until 6 months. That was both our recommendation as well as the interest of the family. But during about the month 5 visit, we did talk about what the simplified diet looked like, what first foods might be introduced. And then this family had the opportunity to, during their grocery shopping, kind of look and see how they would implement that for their child. And then in month 6, we did begin the introduction of 0-gram protein first foods, or what we call uncounted foods in the simplified diet now. And we added PKU Explore. Throughout this whole process, again, the liquid nutrition is really remaining constant and stable for this baby. And next week, you'll hear much more in depth about introduction of solid foods and PKU Explorer by Chanel Suarez in a baby and caregiver centered approach, the introduction of solid foods tailored for PKU. And that concludes this part of the presentation, and I am very happy to now pass it off to Maria, who will introduce our next speaker. So thank you so much.
Thank you, Suzanne, for that thorough clinical review. We felt that as part of a holistic approach to Suzanne's talk, we wanted to welcome a parent's perspective on what the timing and the experience that Suzanne just went over is like within the patient's home. So it is now my pleasure to introduce you all to Betsy Madonna. Betsy and her husband, Dan, are parents to Brody and his younger brother, Cash. Brody is a very active young man who plays several different sports and comes from a close network of family. Betsy is here today to share her experience with transitioning Brody to solid foods when he was an infant. So hi, Betsy. Thank you so much for being here.
Thank you, Maria. Thanks for having me. That was
Great.
awesome, Suzanne. It brought back a lot of memories.
So I wanted to start by asking you if you could just share a little bit about your experience within your family home and with having your new baby with this new diagnosis, and what that was like for you regarding introducing formula and especially those first foods around the 6 months of life.
Yeah, so of course it came as a shock, and we didn't understand what it was, and we thought it was a false positive or whatever it was we were Googling. But we quickly became aware that this was for real, right? And his levels were, I want to say 21, when Suzanne was talking about how, you know, some families have to do a wash, some don't. We definitely had to do a wash, and we did 2 washes with Paraflex formula. So after that, I was breastfeeding, of course, but just pumping. So I was not given the opportunity to actually breastfeed. We instead purchased this hospital grade pump, or rented it, I'm sorry, so that I could get as much as possible, because of course, when you don't, you know, go breast to baby or baby to breast, you know, your supply can go down. That lasted about 3 months because I got on a plane every Monday for work. So eventually I just wasn't able to keep up. So we went from Paraflex and breast milk. Paraflex sounds a lot like PKU Start, of course, that amino acid infant formula. And we went to Paraflex and I believe it was Gerber Gentle Ease. We were told by our dietitian, by our doctor, to actually do what the opposite of was what Suzanne said, which was combine it all into one big 24-ounce jug and use it that way. We did not do that, which I'm happy we did not do that, because we thought a lot about it logically, and of course listened to our clinic, but logically we liked to have it on demand, like Suzanne said. It made it easier for us to make plans and go places and do different things. We alternated from Paraflex, and then the next bottle was Gerber Gentle Ease, and then the next was Paraflex, etc. Brody was had terrible acid reflux. He threw up all the time. And I'll get into that a little when we talk about maybe transitioning to solids. But it was ever changing, right? But not too much. We did our blood Phe levels on the baby's heel once a week. They got back with our levels probably within the next 2 weeks. Unfortunately, it took about 12 days to get levels back. And we would either increase or decrease the Paraflex, right? It wasn't by much, 15 milligrams up, 15 milligrams down. That was basically what we did, just bottles after 3 months.
Okay, great. That's very insightful. Thank you. So when it came time to introduce solids, just based on your own experience, having a PKU young one and having a non-PKU young one, what is sort of the optimal timing from a PKU parent perspective? Some clinics will start the conversation a little bit earlier than others. From a parent perspective, what is the timing of the communication that you think might be best from a family perspective?
It's kind of a loaded question, right? Because I was a first-time mom and I was a PKU mom. So I'm relying on that clinic to tell me everything, whether they knew that or not. So I didn't do anything. Like most of us, we're petrified. We're literally doing everything they tell us and nothing outside of that. So looking back, I wish that, let me back up for a second. We went to applesauce and a little bit of cereal, maybe around 6 or 7 months. We were in contact with our clinic about fee levels and nothing really else. We were told what the level was, go up 15 Paraflex, go down 15 Paraflex, right? For that special formula. But we never went off of applesauce and cereal until he was over maybe 16, 18 months. Because we didn't know, right? Our next clinic visit, yeah, that sounds good. That's good. Okay, moving on. That wasn't great for us, as you can imagine, as any dietitian can imagine. I wish that in the beginning, it was kind of like, hey, here's a sample of a schedule that we're going to go through every 3 months. Your 3-month-old, 6, 9, and 12. And this is what you can expect. I wish it was something like that. Now, of course, it's different for a PKU parent who's on their 3rd child. They know what questions to ask. They know that, okay, typically we need to go to solids. I know Suzanne talked a little bit about a pediatrician. Our pediatrician kind of stepped back when we talked about food. They wanted to know if things were normal with bowels, but then they kind of, a regular pediatrician doesn't know PKU, right? They might have 1 or 2 patients their entire career that have PKU. So we didn't know what we didn't know. I wish it had been talked about ASAP. I do think if I wanted to go down this road, I follow a lot on Facebook. I used to follow a lot more for our Parents of PKUers Facebook group. There is a lot of similarities I see versus, kids without PKU. And now that I have another one and, neighbors, kids, friends, kids, there is definitely a correlation, in my opinion, right? I'm not a professional, between kids with PKU and food therapy and food pickiness and food sensitivity. I don't know if it's because of what we went through. He gagged and threw up every single day for 2.5 years. Whenever I introduced anything but applesauce to him, felt like it was way too late in the game. Had I been told, hey, here's a list of 10 foods. You're on the simplified diet now. Here's 10 foods. You can cube them, make them soft around 9 months, throw them on his tray, see what he does. Do sweet potatoes, squash, bananas, whatever it may be. Don't worry about picking it up off the floor, grabbing the smushed, pieces and weighing them. If a PKU mom or dad is told something like that, we relax a little, and I think it just is a domino effect, and it helps from creating issues down the line.
So it sounds like you did get some helpful recommendations a little bit later on in his infancy and early toddlerhood. Can you share any of those recommendations that really helped your family transition him?
Yes, when we transitioned out of our clinic, we met with a doctor, Dr. Eggerding. If anyone knows her, she is well known in the PKU community. I think she was treating PKU patients since the 70s. We're right outside of Philadelphia, so we went to her practice, her and Ann Starr in New Jersey. Right away, they were like, you got to go to Simplified Diet. They also told me to chill out. They also told me that if you have a bad day, it's okay. The next day will be better. You're not really, you're so high strung as a PKU parent in the beginning. And it is serious and it has to be taken seriously, right? But holy moly, like I should have been in a straitjacket the first year. I wish somebody would have told me to chill out. And that, you know, if the baby's sick, treat the illness. So when we went to Simplified Diet, we also changed formula and realized that the amino acid formula was really one of the reasons he was fully throwing up an entire day of formula and food just by one gag on a solid. We went to Better Milk, which was a huge change, right, to a GMP. And then that lasted a couple months and then went right to Sphere as a 4-year-old.
And it's been a long journey for you and for Brody. And I am happy to report to everyone listening that Brody is a very active young man. We do have a couple pictures to share with everyone. We've been talking so much about him and how great he's doing. You know, the family has come a long way. I just was curious, what is Brody's favorite food now?
He has a lot. I
That's
always,
great.
yes, I encourage some younger, I encourage on Facebook to people who are like, my kid will not even eat bread. They want chips or fruit. Like that's what I feel like that's what PKU kids eat, chips and fruit. They love the salt, they love the fruit. I don't know what it is. It gets better as most kids, non-PKU or PKU, right? But he loves the siete hard taco shells with cut up peppers, cucumbers, some BioLife cheese, and then we actually put we put salsa in it, sometimes balsamic vinaigrette. I know that sounds really weird, but he eats like 2 or 3 of those. It takes a while for him to eat it, which is nice. It slows him down a little.
That's awesome. Well, thank you so much. I know we could probably spend hours just listening. It's very insightful to hear the family's perspective, especially from a clinician standpoint. So really appreciate your generosity in sharing your story. Do want to leave some time open for the Q&A. So if anyone has not already put their questions in the question box, feel free to do so. And I will hand it back over to Elisabetta.
Thank you, Maria. I struggled a little bit with sharing these, downloading and sharing the pictures, but hopefully you saw Brody in his in the baseball. Okay, great. Thank you, Betsy. Thank you so much. It's really helpful and valuable to all of us to get a more well-rounded perspective. We do have some questions, but I just wanted to give an opportunity if Suzanne and Chanel had any questions. We have about 4 or 5 in the queue. Should I go to those?
Well, Betsy, I just want to say, I think it's so helpful that you shared that you almost like wished you had a list of questions at each stage to ask, because as like healthcare providers, I think we don't always know what we don't know. And that's actually would be a great resource for parents that we could possibly build out.
Yeah, I just want to echo what everybody has said. Betsy, thank you so much for sharing your journey. It's really so meaningful and helpful as clinicians to hear from parents and your experience. So thank you.
Of course, thank you.
And you teed my talk up perfectly for next week. So I really appreciate that.
Down to the details of chopped and
Yes, exactly. So thank you. Thank you.
Mm-hmm.
Okay. Well, let's go to the questions here in the queue. So we have the first question, which is for Suzanne. What are some strategies you have given to breastfeeding mothers who want to breastfeed, but are worried about the uncertainty of how much baby is truly getting? I can't imagine asking them to buy a scale.
This is such a wonderful question, and I've never asked anyone to buy a scale, although I have had families buy scales on their own, despite us sharing that we don't think they need them. We really like to explain that breastfeeding is all an estimate for every baby, that sort of everything we're doing is based on our best estimate based on the knowledge we have. So what happens, we kind of explain the process of feeding at the breast, that if they're offsetting the baby's appetite and then allowing them to finish to hunger at the breast, that the work for controlling that Phe level can be done on our end by adjusting the amount of PKU start or Phe-free infant formula that the baby's getting. So we're going to monitor frequently. We're going to know when the baby is getting too much or not enough breast milk, and then we have a meaningful intervention that we can employ to keep that Phe level stable.
I'll also just add, while I also approach this in the exact same way that Suzanne does, I have had 1 or 2 PKU moms who have actually wanted to pump and provide measured amounts of breast milk that just, they still want to provide breast milk, but they feel more confident and comfortable approaching it that way than allowing direct feeding at the breast. And that can sometimes be a strategy that achieves everybody's goals.
So flexing the prescription to the family is great. Nicole has a question. Is there an average or expected duration of time for changes in diet to be reflected in Phe lab values?
That's a really great question. We tend to say like 3 to 5 days is sort of like shown on the Phe level result. Now, I think there's probably, we could see a very high level reflected from just like 1 day of offset intake. It really depends on sort of what's going on in a larger sense. But we tend to say like we see it about 3 to 5 days. And so I think there's another question about like how often we test. So we tend to test weekly. For us, we're able to get a Phe level resulted usually within like 3 to 5 days. So we're kind of able to report that back, make a change, and get another Phe level quickly. It depends on the lab though, and how quickly that can get resulted.
And actually this ties right into Zazil. Hi Zazil from Mexico. Question. She actually would like to know during those early months of your case, how often do you measure blood Phe concentrations?
Yeah, so we typically measure weekly throughout the first year of life. Occasionally we will measure a level sooner than weekly, especially at the very beginning. But that's if we know we're going to get the level. We have the benefit of like an on-site plasma amino acid lab. So if we know we're going to get the result within 24 hours and it's going to be very actionable, and we think we really need that for the baby's care, then we'll do that. But for the most part, weekly. And that's also the GMDI guideline recommendation. I will say there's also cases of like less severe PKU where you might have much more stable Phe levels and probably on less amount of formula, and then those levels might be tested with less frequency.
Anything from your side, Chanel? West Coast?
West Coast.
The same?
No, same for us. I was going to echo what Suzanne said, actually, if she didn't mention it, which is that for some of those cases that are more mild PKUs, we may not test weekly. We may space it out to monthly or every 2 weeks. It's really going to be driven by the patient's kind of tolerance.
Okay. On to Amanda's question. Do you see slowed growth when providing PKU start first, then going to the breast due to not completely emptying the breast and missing hind milk?
Yeah, this would be a really wonderful question for a lactation consultant to answer, and I am not one, but it is my understanding. So there's like 2 things here. One, the breast milk supply adjusts to what is happening sort of in the baby's like day-to-day life. So typically once there's a sort of ebb and flow to the formula provision and the breast milk, eventually it can take some months, but the mom's supply adjusts to that. We also, I think there's some new information about like hind milk and fore milk and sort of exactly when that's happening in the feeding process. And so it's less clear that fore milk's always right at the beginning and hind milk's always right at the end. But again, a lactation consultant could give you a lot more on this. But finally, I mean, I think the summary is that no, we don't see growth impacted when a baby is feeding at the breast with PKU. We see really wonderful growth outcomes.
Do you typically use a simplified diet approach even with classical PKU?
We do, yeah.
Yes, we do too. And this is another great plug-in for attending my talk next week, because we will walk through a classical PKU with the simplified diet.
Brilliant. When doing, this is Jennifer, when doing a blood spot, how many hours after a feed do you suggest?
Oh, that's a great question. I tend not to suggest. So, because I think there's like only so many hours between feeds, only so many times when both caregivers are home, which is really what's required to get that heel prick, especially in the early phases. I think when we get older kids, we may start to say, oh, it's like best if, always at the same time of day, maybe on an empty stomach. But really in this early stage, like we are just trying to get it all done in the day, and whenever the family can get it is fine.
Okay, here comes a small case study. It's Friday afternoon at 4:30 and a newborn screen comes in for elevated feed PKU. How quickly does your clinic get an infant started on PKU formula?
It would depend on how likely it was. Like, so we use both like the elevation, we think about the elevation, and we also think about the like feed to tyrosine ratio. If we feel like it's a very high likelihood, we would try to get that baby started over the weekend. And yeah, I don't know about you, Chanel.
Same. I think if we have a high suspicion for a classic case of PKU, we're looking to get started before the weekend. And, this is when we really lean on our amazing reps, such as, at VitaFlow, I know who I can contact right away to get PKU start to that baby in a timely fashion. So I don't think we would wait until Monday. No.
Okay. And I think this is the last question. Have you ever needed to concentrate PKU formula to assist with poor growth along with breastfeeding?
I personally have not, but I think it's like it would be a very reasonable thing to do if you're trying to like achieve an adequate growth outcome, just like a baby without PKU, where you might concentrate an infant formula to be higher than 20 or 21 calories per ounce. You could use that alongside breastfeeding, and that would really just depend on sort of the amounts and the dilution that you were looking for. So we might go up to something like a 22 to start and then raise to like a 24, similar to how you would do it with any standard infant formula.
Well, that's all the questions and really all the time. So this was a little bit rapid fire in the end. Thank you all. Thank you to the presenters. You all did just a brilliant job. It was a really, really helpful program and time together. Thank you to all of you who participated and put in your questions. So please join us next week for the part 2 of this webinar series. Let's see if I can go to the slide that I intend to. It's next week, September 21st, 1 to 2 p.m. Eastern Standard. So if you haven't already registered, when you fill out the evaluation form that's going to pop up here in a little bit, there'll actually be a link for you to do so. But it'll be Chanel, and Suzanne will join again for the Q&A, and she'll be covering solid food introduction and some helpful strategies to support a smoother and more caregiver and baby-centered experience with solid foods. Please fill out the evaluation, because we really value your feedback, and we really look at that feedback and we try to improve and do better. On behalf of VIA, VitaFlow, and association with you, we really hope that you enjoyed this and found this information practical and helpful, and we hope that you enjoy the rest of your day.